I think, well, this is a great crowd. I really, again, want to thank everybody for coming on this crisp evening. Although, as the CEO Karen Oldfield noted, the sun is out up above our heads here, so we know it's going to be a warm and toasty evening here in the hall. So, thanks again to everyone for coming, and I think everyone's had a chance to mill around at the tables in the back, and certainly I know at some of the previous sessions that I've seen, there's been questions about virtual care and how do you register for virtual care? Well, there's someone here who can help you do that tonight. So that's that's one of the benefits of coming here this evening. But certainly there's always an opportunity to learn more. If you just send us an email, we'll certainly get back to you. So I hope you found all that information useful. We're looking forward to fielding some of your questions. I want to let you know that we are going to be recording this session of the evening tonight. So it's going to be posted online. So if you want to go back, if there's a question you didn't ask, you can certainly go back and watch the video online, or watch the videos of some of the other sessions. I think this is the eighth or ninth one. Community conversation that they're happening all around the Western Zone and all around the province as well. So coming to a community near you. At this point, I would like to welcome the Honourable John Lohr, the Minister of Municipal Affairs and Housing and the MLA for Kings North. Minister.
Thank you, Fraser. It's a pleasure to be here. I just want to begin by first of all saying that I would like to acknowledge that we are in Mi'kma'ki, the traditional territory of the Mi'kmaq people. And I do want to welcome all of you here tonight. There's one I notice, a colleague, former Minister of Health, Honourable Leo Levine. I want to acknowledge Leo's presence here tonight. And I do want to introduce the Deputy Minister of Health, Jeannine Lagassé, who has an incredible wealth of knowledge. I know I've had the pleasure of hearing her speak a number of times about health issues, and our CEO of Nova Scotia Health, Karen Oldfield. So I'd like to welcome them and thank them for being here, and thank them for doing all of these different sessions. It's good, and I know there's a lot of staff of Nova Scotia Health here, and staff of the Department of Health. So thank you to all of you too for all the work you do. So I'll pass it back to Fraser.
Thank you very much, Mr. Minister. And I guess at this point, I would invite the CEO or the Deputy Minister to maybe have a few opening remarks.
Great, thank you, Fraser. Good evening, everyone. I think we just wanted to say also that because we're a distance away from you, we've taken our masks off because it's a lot easier to hear through the mic with our mask off, and we feel that we're kind of far enough away that we're able to do that. But thank you very much for coming out tonight. It's nice to see such a crowd. I said to Fraser earlier, I think this might be one of our largest crowds so far, Karen, right, that we've had, so which is fantastic. And we know that a number of you have come here for different reasons. That we know that probably a number of you don't have a primary care provider. That some of you may have waited very long for surgery or treatment. And we're here tonight to talk with you about that. That what we would really like to do is have a question and answer session. So I think Fraser will read some of the questions that were pre-submitted, and we'll take questions from the floor, but really we would like it to be a discussion with you, so that we can, through our answers, provide you with some information about what we have been doing over the last 14, 15 months since September of 2021, when Karen and I both started our positions. We started at the same time as Minister Michelle Thompson, the Minister of Health and Wellness, who unfortunately was unable to be here with us tonight. But just after we started in September 2021, Karen and myself and our other health leadership team colleagues, Janet Davidson, who's the administrator of Nova Scotia Health, and Dr. Kevin Orrell, we toured the province with the Premier and Minister Thompson to hear from healthcare workers. We called it the Speak Up for Healthcare Tour. And we covered the entire province. Karen and myself, the team that we were with, went from Neils Harbor to Yarmouth and all points in between over 4 days. And we spoke to frontline healthcare workers of all types, physicians, nurses, OTs, PTs, But we also spoke with people in housekeeping, we spoke with people in dietary, we spoke with pharmacists, just anyone who wanted to come out and chat with us. We listened and spoke with them. And we heard both the challenges that they're facing and a number of solutions that they had identified. Because often the people who are working closest if they know that there's a challenge, they've also been able to identify a solution. So we took all of that information in addition to the items that the Minister has been asked to complete in her mandate, and also the Minister of Addictions and Mental Health, and the Minister of Seniors and Long-Term Care. And we created a strategic plan called Action for Health. And we released Action for Health in April of this year. And you would have received some information, I believe, when you registered, and then some cards also when you came in this evening. And Action for Health sets out the 6 solutions that we've proposed that will get us to a world-class health system. So we know that where we are now, tinkering around the edges, changing a few things here and there is not going to get us where we need to go, that we really need to fully transform the system to make it world-class for all of you and for all of Nova Scotians, so that you can get the care that you need and deserve, that it's ready, responsive, and reliable when you go to get it. So that's really kind of a bit of background as to why we're here. And we've had great discussions in all the communities that we've been in, and we expect the same will happen here tonight. And just thank you very much for coming out. We learn something everywhere we go, and we hope that we're able to give to you some information that you're looking for as well.
Great, thanks, Jeannine. And good evening, all. I'd like to start typically at our sessions by just with a show of hands, the healthcare workers that we have in the room. And I've met a couple of retired, so you should feel free to put your hands up as well. Great. So we have a huge number of current or recently current healthcare workers in the room. So I want to say thank you for starters, and I like to remind people, it wasn't too long ago, at the very beginning of the pandemic, when our neighbors and businesses and people were banging pots for healthcare workers and holding them up as, the heroes, certainly at the first part of COVID. And somewhere over the past 3 years, that went away. It just went away. And so we need to bring back that feeling, because it's just not right how, some of our healthcare workers are being treated. So I just want to start with that. And thank you for what you do, and recently retired and retirees. I'm sure you went through many years of providing care and service to our fellow Nova Scotians. So thank you all. And because there were so many hands up, I know this could be a fun night. So let's Jeannine and I like to roll with these things. Like, everything's on the table. We want to hear, though, not just the challenges, because we go to a lot of sessions and we hear there are certain themes, but if you have solutions, that's what we really want to hear. Because we know you're sitting around your dinner table. We know you're talking at your coffee club. We know you're talking about, why don't they do this and why don't they do that? Well, guess what? We're they, and we'd like to know what, the possible solutions are. So I encourage the issue to be identified, but if you think you have an answer, that's what I really want to know, right? Like somebody, I don't know if Mr. Lynch is here. Mr. Alan Lynch. Okay, there he is. I read his question tonight, and he had couple, but one of them was, yes, 4 to 6 years to train a physician and a nurse, but what are the short-term solutions that get us nurses now? Okay, I'd like to hear what you people think about that.
I have a solution.
Okay, I want to hear it.
Yeah, allow every unvaccinated nurse to go back to work in Nova Scotia. That's one right there.
No. We're going to come to that. We're going to come to that.
For the benefit of the people watching on video, the statement was about letting unvaccinated healthcare workers go back to work.
We'll get to that, because I know that question has arisen, and it has arisen at every other session as well. So we'll get to that. So Before we dive into the Q&A, what I'd really like to do, if you don't mind, I'm going to invite our Western Zone leaders. So I'd like to invite Tanya and Cheryl, and if Allison wants to come up too. I want you to know who they are, and I want you to I would like them to briefly tell you what they're doing in the zone, so that you know, everybody knows what our leadership here is doing. They didn't know that they were going to be put on the they didn't know this was happening, but it doesn't need to be a book. It's just short version. Okay, short version. There you go. So we have Tanya and Allison and Dr. Cheryl Pugh and somebody I don't even know.
Darlene Davis.
Oh, sorry, Darlene Davis. So welcome. And just very quickly, if you'd like to share what you're doing here.
So good evening, everyone. We're the other part of the they. I'm Tanya Nixon. I'm the Vice President of Operations for the Western Zone. And together with my colleagues here and those in the back of the room, we're spending a great deal of time concentrating on health human resources and recruiting and retaining, and also looking at ways that we can improve access to care. A big part of what we do is going to communities and talking to people like you, and as Karen has indicated, listening to not only what the problems are from your perspective, but hearing what some of the potential solutions are. So about a year ago, there was an engagement tour with staff and physicians. About 6 months ago, in the Western Zone, we talked to communities where there were regular and routine rural emergency room closures. We talked to communities about those closures and what we could do together to reduce those closures. And tonight we're here to listen and to learn from you as well. So thank you for coming.
Thank you, Karen. Tanya. I'm Cheryl Pugh. I'm an obstetrician gynecologist. I work with this amazing team as well, and I'm located in Bridgewater, but we also service the entire Western Zone, which goes from Yarmouth, Bridgewater, Kentville, and everything in between. Those are the 3 large regional centers. My role as a physician is to bring the physician lens to everything that Tanya just said. I am the physician lead for the multiple disciplines where physicians participate in clinical activities and increase the engagement of the physicians in all of things recruitment, retention, clinical care, and access to services for you as our patients we want to provide excellent care for.
I am Darlene Davis, and I'm the Interim Executive Director for Community and Rural Health. Relatively new in my role, about 3 to 4 weeks into it. And I'm currently making my way around the zone to the rural and community sites, trying to get to know people, doing a lot of listening, trying to understand what the issues are, what people are looking for, what's important to them. So I'm hearing a lot about access to care and timely access to care. So I've been enjoying my visit so far, looking forward to meeting a lot more of you in the weeks to come.
I'm Allison Lamb, and I am the Executive Director of Acute Services in the Zone. So I recognize some faces here. I'm from the area, and so my responsibility is the regional centers. Of late, my days have been really focused on access. We have a lot of ILI through the area and our pediatric patients, and we've been working collaboratively across the province and with the IWK to facilitate care. This weekend we had a pop-up clinic. We worked really collaboratively with our primary health care. We knew a lot of people needed to receive less urgent care in a timely fashion. We had seen a lot of people in our emergency department in Kentville, and how did we relieve that? So we work across the province those are solutions that come to fruition, and we act on them quickly. So we spend a lot of time doing that, getting timely access, whether it be for surgical services, which fall within my portfolio, and thinking about how we can deliver services in a different way. So from the opportunity to really increase our ability to do day surgeries when it comes to hip and knee replacements. We've had a significant increase here at Kentville, at Valley Regional in the last little bit because of that. So those are some of the innovative approaches that we're taking within our regional centers to really allow access to care.
That's great.
Great. So thank you for sharing. And you have a great team here. They work very hard on your behalf and on behalf of the whole of the zone. And as you mapped out the geography of the Western Zone, it just reminds me again, Cheryl, that it's a big zone. It is a very big zone, and I'm mindful of that because, you know, the resources, like top leadership only goes so far, so we have to be mindful and make sure that that their communities are reflected in our leaders. So, over to you.
So let's get things underway, for sure. Thank you, Karen, and thank you to the leadership team in the Western Zone. As the CEO noted earlier, you know, when people say, you know, why don't they do this or they do that? Well, they are in the room tonight, so they're ready to hear your questions. We've got a few people here tonight, and I know you've been writing some questions down. We have Tamara and Rachel who've got the microphone, so if you'd like to stick your hand up in the air and ask a question, they'll certainly come over with the microphone. Try to speak right into the mic if you can. Or if you have a question card that you filled out that you'd like us to ask, they'll take those too and bring them up, and we'll ask those on your behalf. So as I mentioned earlier, we also invited people to submit questions online as you were registering, when you registered for this evening. So I'm going to start maybe just to kind of get the ball rolling, ask a few of the questions that were submitted online. And I certainly encourage you to ask questions. I know I've watched, this is the first session that I've actually been to, but I've watched the rest of them online. And Karen and Jeannine are very friendly, so I certainly encourage you to stand up and ask a question. But like I said, I will get the ball rolling here. And these aren't, I'm not throwing you any softballs here either. These are going to be some of the tough ones, although I doubt they're anything that you've not heard before. Okay, well, we're starting out something I think that's on a lot of people's minds. Considering that the wait list for doctors has increased from 71,000 to 110,000 since the government came to power, what specific actions have you taken that have resulted in an increase in the number of people waiting for doctors instead of a decrease? Or I guess in another way of saying is, what are you doing to try to get that number to decrease?
I think Jeannine should start tonight, don't you? Thanks.
Sure thing. So very early on, well, right after in September 2021, the government did create the Office of Healthcare Professional Recruitment, and to put a focus specifically on recruitment. So the office is led by one of the associate deputy ministers in the department and the vice president medicine at NSH. So we're really working together to make sure that we're doing as much as we can in regard to recruitment. And we're looking at everything in relation to recruitment. So actually going out and finding people, but looking at, you know, how people come in through immigration, how we train people, what our licensing colleges are doing to help us to get people through and licensed faster. So there's a number of different things, policies that we have currently in place that may impede people getting into and trained through the system quickly. So we're looking across and then taking all of that and then actually heading out, hopefully making the process smoother for people, but also then just going out and looking for people. They've done a number of national and international trips to recruit people, and I can tell you are on it every day. And I think our zone leadership would say the same thing, that they spend a lot of time as well, you know, when people are coming to the zone, physicians in particular, to show them around. But I would say, Fraser, one of the big things too that, you know, we need you folks to do is we like to say, like, we are all recruiters within our community. And so it's about, you know, your community being welcoming, and because we know that we recruit maybe one person in the family to do something in the zone, but it's the whole family who comes, and it's that family rooting and being successful that gets them to stay. So I just would like you to think about that, as if there's new people in your community and you see them, that really it's about making them feel welcome and wanting to stay.
I agree with all of that, and I would just add a couple of points as well. So it's, you know, I was just speaking to Minister Lord before the session started, and I looked today just so I had these stats at the ready, and we could identify 36 vacancies for family practice doctors in the valley, and notwithstanding, there's been a good pace of recruitment and an excellent pace of recruitment for specialists, but we're still down 12 specialists too. Okay, so What are we doing about that? Yes, recruiting. Yes, working to have internationally educated physicians able to practice in Nova Scotia more easily, but also setting up streams so that Nova Scotian students who have gone away to medical school, whether it was Australia or Ireland, so that they're able to come home to their communities. And there's actually, I'm pretty sure there's somebody from Kentville, definitely in the Valley, who has a young fellow who's written me several emails about how keen he is to come home. So we know that folks who are educated outside of Nova Scotia need to find paths to come home. So we've actually worked with Dalhousie and with CARMS, I'll get this wrong, Canadian Association of Residence Medicine, I think. Matching. Okay, thank you, matching. So, you know, we've developed a new pathway for those Nova Scotians who have been educated outside of the province to come back. So this year in July, we will graduate the largest number of family practice grads in the history of Dalhousie. So this is very positive. But that's just step one. Then we need to reach out and we need to put our little arms around them and find places in Nova Scotia where they want to be. And this is the conversation I was having with Minister Lord before the session started, because like I'd love to know, I don't know. I do not know the answer as to why the Valley is in this spot. Yes, retirements, like I'm sure there's a ton of reasons, but the reality is it's such a great place to live. It's not that far from the city. The weather's better. There's good golf courses, etc., etc., etc. So I really don't know the answer to that. The minister said that one thought is that, you know, the community, maybe we were a little complacent in the, you know, I'm not talking about yesterday, I'm talking about several years ago, or maybe we just didn't look out far enough. It doesn't matter, because we are where we are, and we need to, you know, we need to rally. So, for example, in one of the sessions that we held last week in Lunenburg, the South Shore Regional Hospital Foundation has specifically identified a person to help recruit. So the foundation is in effect paying for the salary for a recruiter in that area. Every community does something a little bit differently. And, you know, I think community groups can learn from each other. For example, they have a really super community group in Pictou, Healthy Pictou County, I think it's called, and they have a lot of best practices. And it wouldn't matter where you go in Nova Scotia, different communities do different things that work for those communities. So the only thing I'll just further add that the government, the provincial government did set aside a fund, I want to say it's $2 million, for communities to apply for additional help with marketing and you know, things that could help to recruit physicians. So that is available to community groups who are interested. So I could go on, but I'll stop there.
Thank you very much. And again, sir, encourage you to, if you have a question you'd like to ask, raise your hand, or if you have a question card you would like to submit, raise your hand, and Tamara or Rachel will come around. We have a question right here in the, close to the front. Rachel? It's a big room, so it takes a while to get the mic to you.
I was going to ask in regards to the recruitment of new physicians. You're saying a big graduating class coming out of Dal. I know quite a lot of physicians are graduating with massive student loans debts. Could potentially an option for keeping them here be some help with their student loans?
Yeah, we do have an incentive program for physicians in rural areas, and it's I think it's up to $125,000, and so it's over a number of years, and so they would get a payment up front and then a certain amount each year. but it is specifically for physicians who are settling outside of HRM, and I'm pretty sure it's up to 125,000.
Yeah, so that's the kind of solution that I'd like to, I want to hear your ideas. So we've definitely burned a lot of brain cells trying to think of, solutions, but we're only a few people. So, pardon me, Dr. Bob? Okay, Doc.
I think I can talk loud enough without the mic.
Okay, perfect.
But for the benefit of the video,
for the
and the recording, if you
Okay.
could use the mic, that'd be great. Thanks.
Thank you.
Apropos of that, I want to talk a bit about the, what do you call them? Disincentives for people to go into family practice. Perverse incentives, that was the word I was looking for. People graduate, as you pointed out, with debt. And when they look at the possibilities, they could work in a office practice. That involves currently being something of a business person and paying out of your overhead. Or you can go work in an emergency room, or you can work as a hospitalist, where you get paid, I think the last time I looked it was $140 an hour, with no overhead, no administrative responsibilities, and frankly, time to do your paperwork in your paid hours. So if you're a recent graduate, it's a no-brainer. What are you going to do about that?
What are we going to do about that? So you're absolutely right. And this is one of the issues that we've had to turn our mind to. And in fact, many grads want all of the above, because they like to have the rotation and not just do one thing. So we approach the problem from the perspective of meeting people where they are. So what that means is we need to understand what grads are looking for. What do they want? How can we entice them by meeting them where they are? So we do try to understand where they're coming from. And so I just want to talk about a couple of the models. So for example, this will be a long explanation, but it will come to the point. We do know that in medical school, they don't necessarily teach Business 101. So, not how to schedule, many things about running a business, which in effect is an office practice, can be an office practice. We know these are things that are not necessarily taught in medical school, and not all doctors have business degrees. So how do we help? One of the things we did early in 2022, we put a team together, and the team was comprised of a couple of industrial engineers from NSH, a couple of folks from Dalhousie, and we put the team together to go and look at the Dalhousie family practice. And the Dalhousie family practice it's a collaborative practice that's run as between NSH and the Faculty of Medicine. And we wanted to look at it to see how we could have that practice take more people from the list. Okay, so the folks went in for 4 days, Thursday, Friday, Saturday, Sunday. By Friday night, the team lead called me and said, Karen, without doing too much, we will be able to take 2,500 people off the list. By Sunday night, called again and said, we will be able to take 3,500 people off the list. Now, how could they do that? They did that because by mapping out each professional person in that practice and determining what would be required to have each of those persons work to their full scope of practice. And of course, one of the obvious things, I shouldn't say of course, but one of the obvious things which emerged is that it takes a physician on average 60 to 90 minutes to onboard a new patient. So to take the history, get all the information that they need. So 60 to 90 minutes.
I can't imagine them doing that. That won't work.
Well, that won't work.
Hence the rest
Right?
of the story.
Hence the rest of the story, okay? That won't work. And but there's other people who can do that, and there's other people who should do that. Okay, that's the point. So this is a tiny little tale at a school, so don't tell on me. We asked Dalhousie before we even did this project. We said, okay, look, we want that clinic to take more people off the list. And we got a proposal, and the proposal said, yep, we can take more people off the list, Karen. We need 13 more physicians, and we need $26 million. Okay? That's when we put the team together to go in and have a little look-see. So we didn't need $26 million. We didn't need 13 physicians. We did need people, but to support the work so that physicians were working where they needed to work, the OT, the PT, the folks in that practice. Anyway, to make the really long story short, what we did as the outcome, and this is going to come to Dr. Bob's point, to answer to his question in part, we have now formed a, rapid onboarding team is what we're calling it. So it's comprised of an industrial engineer, a practice coordinator, and one other person from the medical affairs team that are available to any physician in this province, whether they work for NSH or they have their own private practice. Anybody who wants that team to come in and have a little look-see at their schedule and ways that they might be able to, we can help them to onboard patients onto their practice so that they don't have to do it. And so we had this session at the forum last week. A specialist in urology said, well, we have can you come into our office? We were going to pay $30,000 to have an outside consultant do this. Well, yeah, we can do that. This team can do it. So what we ended up doing with the Dalhousie practice, they took the 3,500, so that group of people has been onboarded into the practice. We also were able to learn better methods to help teach the residents how to do this so that when they set out on their practice, they're better able, they know how to do it. And we're able to scale that particular model across the province. We're going out to 3 different clinics after Christmas, and it looks like we'll be able to take off maybe 17 to 20,000 people off the list by doing things like leaning out the practice, doing smart things, putting a team that helps the physician do what he or she does best and what everybody else in that group should be doing. So it's not a direct answer to your question, Dr. Bob, but just to let you know the kinds of things that we're thinking about and being able to help a physician who, I can't even imagine what it's like on a Sunday night when your week's just going to be a nightmare and there's no getting out from under it. It's just going to be a nightmare every single week. So by helping to smooth out the schedule, it is a way that we're able to assist.
I think that was a comprehensive answer, because we had another question about healthcare team members working to their full scope, which you addressed as far as physicians go, and you went back and actually addressed the question about names on the Need a Family Practice Registry as well. So you knocked 3 questions.
No, we have some things we want to say about the list, and so Jeannine, you can talk about it. We'll go back and forth on this because we've got a bit to say. I shouldn't say a lot.
So we know that the list keeps growing. We know that. But the list is not a very effective tool right now for us because it's just a list. There is no way for us to triage the list. There is no way for us to know who might need care faster on that list. There's a number of things about it that it's just static. It's not really helping us. So we have a team that's been put together, that has been looking at this and figuring out how we can do better. So I would say, to a certain extent, stay tuned, but we are looking at and going to be implementing in the new year ways to make that a better list for you as citizens, so you get better information off of it, and that the providers can get better information off it as well, so that we are ensuring that the people with the highest needs are getting placed quickly and being able to target better how we are getting services to people in the most efficient manner. So it's all about, and these are the things that we've been trying to focus on with our teams, is that, so it's not that we're not doing away with the list at all. We just want to use it in a different way. And we're trying to be innovative and thinking really differently about what the purpose of the list is. And always with our first thought, how is it best for citizens? What do you need from the list that complements also what we need from the list?
So on the list, I think I just want to make sure everybody's very clear on this. Are there folks on the list in the room here? Okay, and do you all know that because you are on that list, you are eligible for virtual care? You all know that? Okay, so we have a person here who can help with virtual care, but here's 2 or 3 points. If you're on the list, you can sign up for virtual care. If you sign up for virtual care, so the physician or nurse practitioner who sees you will either write the prescription, if that's what it is, will refer you to a specialist, if that's what's required, or will refer you to be seen in person. And you will be seen in person at a primary care clinic, which you have one here there's one in Middleton for sure that we've gone through, and there probably is one here in Kentville, I just can't remember. So you will be seen at a primary care clinic. Here's the irony. The primary care clinics are working quite well. They're not all same day, next day, but they're not too bad. So now we have the irony of people who are on the list can get in to see a primary care clinic and be seen faster than somebody with a doctor who might be 4, 5, 6 weeks out. So now we have a different problem, okay? Yes, no, it's the fact of it. So we solve one, we have another. So they're both problems. And then we have the issue of some people love virtual care for some things, not for all things, okay? If it's a renewal of a prescription, if it's something easy, it's so easy. So now we have people who are not on the list, but who want virtual care. So we're also now working double time to look for ways to scale virtual care. And people have to appreciate it. It only really became a thing in, I guess, what year? Day's turning into night for me. 20 or 21? 21. So it's really...
COVID.
Hey?
During the COVID era.
Well, now we're in a tridemic. Okay, this is what I've deemed this week to be a tridemic area. So the list the virtual care has been like, it's been created at lightning speed, like 15, 16, 17 months. So great work's been done, and now we have to look for ways to extend it to everybody in the population who wants to be seen virtually. So I'd like you to give your commercial on being careful about what provider to see virtually. Jeannine, please.
So as Karen has said, that everyone who is on the list is eligible to participate in virtual care Nova Scotia. Please be very careful about when you are seeking out virtual care. If it's virtual care Nova Scotia, it will be very clear. It is a service that is run by the province, staffed by folks who are with the Nova Scotia Health, and it is a service that we stand behind. If it does not say virtual care Nova Scotia, then it is not a service that we license or have anything to do with. So we just want to make sure that folks are very, very aware of that.
Thank you for that explanation. I know we often get calls from MLA offices and whatnot about the difference between your virtual care in Nova Scotia and other options out there?
Well, like Maple's okay, and Maple is the backbone of virtual care in Nova Scotia. You will pay for Maple, you know, $69 or whatever it is, it depends. But then that is a platform that's available after hours or on weekends, which we don't have that coverage yet for virtual care in Nova Scotia, but we're in the process of building it out. So just beware is all I would say.
I saw a hand here, but I think earlier I did see a hand right here. Tamara?
Good evening. Given that so many people are going to university these days and many, many more people are getting advanced degrees, and you mentioned that we graduated the largest class of general practitioners, is there a plan in place to continue growing class sizes every year to keep up with population growth and as doctors retire?
That's such a great question. You know, you probably saw the recent media about Cape Breton University doing a feasibility study as to whether or not, you know, a second medical school in Nova Scotia is something that we should be thinking about. And in addition, they already have entered into a partnership with Dalhousie University for 5 seats. So they have 5 seats currently at Dalhousie, which are earmarked for rural physicians. And those doctors or those students entered on the understanding that, and they've actually signed return to service agreements that will require them to practice in rural areas of the province. So even if CBU proceeds with a medical school, that's a number of years away. It's possible that with an enhanced MOU with Dalhousie, they would be able to do more. So the issue with Dal is simply infrastructure. How many teachers, how much faculty, how many labs, it's infrastructure. So in order to keep adding seats, we would need to expand the infrastructure. So that's all of which is possible. So I think part of the question is, where's the fastest, easiest way to do it? Cape Breton or part of Dal? So that discussion is very much on the table. I don't know what the answer is going to be. In the meantime, you know, we're talking about 1 seat, 2 seats, 5 seats, 6 seats. It's not a lot of seats. And so, you know, we recognize that, and somehow we've got to find a way to do more, which is why we're looking at CBU.
Yeah. And I think the other part of that, the answer to that as well is we're working very closely with all of the post-secondary institutions that have healthcare programs in them to make sure that, you know, the program fits for what we need today. Because we've heard a lot, right, about, you know, people graduating from a program, still taking considerable time to be ready to actually work floor ready, as we would say. So we're working really closely also with all the universities, community college, and all the programs to say, you know, is your program still what we need it to be today? Is it as fast as it can be? And still, you know, make sure that the students have received all of the education that they need. And where can we change some of our practical learning as well? So I know that Karen's really supportive, you know, of clinical placements, people when they need their practical work experience, ensuring that no one goes without a placement. And I think that sometimes we haven't been as aggressive on that as we should have. And so those are the other types of things that the other stones we're trying to turn over in relation to education and getting people trained, educated, qualified as quickly as possible.
A final comment, like I believe this passionately. So we have in this province some fantastic universities. So I personally went to St. Mary's, also to Dalhousie. I was the chair of the board at St. Mary's. I know that university very well. I know the quality of their science program, and any other university in this province would have wonderful science grads, as an example, or kinesiology grads, or dietitian, or nutritionist, and so forth. And these are grads where, like, NSH does not hire a huge amount of dietitians or nutritionists or kinesiologists. But why can't we find a way to bridge these grads to something in our healthcare system? Because the reality is, health, it's actually where the action is right now. There's a lot of innovation. It's very interesting. We need people. And so the thing that I'm starting to toy with now is how do we identify a role in the healthcare system that a BSc grad could, with some bridging, could do, okay? Or a nutrition or kinesiologist. Like, you cannot tell me that we cannot do that with our talent here in this province. So that is where my head is. That's what we're looking for. So it's bigger than just kind of Jeannine and I. We need to actually do some work inside government, but we can do that. So that's what I'm thinking. So it's a long answer to your question, but it's a very important question. And you know, there's been a lot of, it really makes me crazy when we can forecast and we can see what we need, but we don't do anything about it. So shame on us, right? And so we're trying really hard to use the demographic data, use all the data that we have, and use it smartly to plan.
Thank you. I see we had another question in the front, but we had one over here. Rachel, if you want, you've been waiting for a little bit.
This will be an easy one for you. You've just been solving the big toughies. My name's Roger Bolt, and I'm a user of your services, unfortunately, since coming from Ontario 3 years ago. We were fortunate enough through Family Connection to get a family doctor fairly quickly, within a year. And she asked me if I wanted to be a volunteer as a patient family advisor, and I said yes. So I've been involved in this kind of volunteer role in the Western Zone management team, and I've also been involved in a provincial task group to develop a strategic plan for chronic illnesses and wellness. And through there, I've learned quite a bit of stuff. I don't know if I've made a difference, but one of the things I've encountered, because COPD is my favorite friend, about a program called Inspire. Right. In fact, I saw it in the minister's mandate letter from the good Lord himself. And Inspired, many of you will know, but Inspired is a program developed in Halifax, I guess, around 2010, and it takes services out to people in their homes. The target of it is to keep people out of the hospitals and the emergency departments. I was surprised to learn that COPD and respiratory illnesses drive most, over 50% of the cost in hospitals and something like 29% of the costs in emergency departments. Whew. And this Inspired program costs about $1,000 a patient. It involves 1 to 4 visits, education, supplemental, but to get access to it requires you to have a certain level of challenge in your OPD sickness. This is, amongst other things, requires a spirometry test. I'm getting to my question. The queue for the spirometry test. Now, the business cases for Inspire say that for every $1,000 you spend, you get a return of about $20,000 in the next 5 years on hospital and emergency department costs. Boy, my banker would just drool at the return on investment of that thing. So, and we're about to have it rolled out here in the valley, which everybody's happy about. But my question is, for my spirometry test, I had to wait about 9 months pre-pandemic. The current queue is about 9 months, and I find out the valley really isn't that bad. In Dartmouth, it's almost 2 years. So here we have this bottleneck in the funnel to get these tremendous savings. And my question is this: why do we tolerate those kind of queues in the system when there's such promise, if we expedite, like, they don't work evenings or weekends, I mean, a businessman will run into that problem and say, we want to sell cars, we don't want to stack of customers up for 9 months. That is not brain surgery to solve those kind of queue problems. That's my question. Why do we tolerate them?
Well, Karen and I don't, is what I would start with. But I think that there's a number of things to your question. I think that, as you said, that the expansion of that particular program is in the minister's mandate letter, so you can expect that that one will absolutely continue. Not that program in particular, but in some of our other programming, surgical is a good example of this, that we don't have single wait lists, or we have multiple areas, multiple ways that people can enter into, right? So for instance, in the work that we're doing in transforming surgical is going to a single entry referral system, so that people will actually be able to know where they are on the list, what their options are when their name comes up to go to different places in the province to receive services. So I think that in all of our issues where we have waits like that, they are being broken down by teams, as Karen had said before, the type of teams that we've put together before, right? So people can actually see what is causing that actual delay. Is it an equipment issue? Is it a provider issue? Is it, and so I'm just saying, like, for various programs, that's the types of things that we're looking at, so that we can then target what it is that we need in a particular program to get those wait times down. That we're very committed to getting the wait times down, but sometimes it's not just one thing, it's a multitude of things that gets us to that backlog, but that we're pulling the issues apart and then figuring out how to get people the service as quickly as we can.
The manager of the respirology department, say, at Valley Regional, not have the authority to address that kind of a problem and fix it? Sorry.
Yeah, we're backing and forthing of what their authority would be on the budget side. I think, they certainly, let's put it this way, it would definitely be part of budget, like this year's budget. Inspire is 100% supported. We don't like the wait list. There's a huge ROI, if you want to put it in business terms, and Allison's going to answer your specific question.
So thanks for raising it. We have hired the coordinator for Inspired, and some other from the specific Inspired program have been hired recently. The bottleneck is from our respiratory therapists actually have to do the testing that you were talking about from the spirometry perspective. And actually, we don't graduate very many respiratory therapists in the province on an annual basis. It's a 4-year program. So it's the actual human person to do the testing that we're short. And they also serve 24/7 care in our departments. Obviously, the RTs are caring for patients on the floor as well. So it's juggling all of those demands. But we actually have a very small respiratory program, and certainly an area to enhance, because we have lots of people with COPD, and their ability to do testing continues to grow. So forecasting what we need from a respiratory perspective is increased. But stay tuned, we're working through it as fast as we can and realigning resources now. We have some Inspired growing across the province.
Our respiratory college is approximately 350. That's it. 350-ish RTs in the province.
Yeah, so I mean, we need more. It's the same with medical lab techs. I mean, there are certain professions and technical positions in the province where we talk about expanding seats at the medical school, but that's just one. There's numerous. So that is a definite bottleneck.
Yeah, and there were periods of time relatively recently where in some of these programs there were no graduates, right? That at various times the programs were actually decreased. So to Karen's point, that's why now we're being so careful with looking at projections and looking at the demographics, so that we hopefully that doesn't happen again.
Thank you, and thank you, Allison, and thank you for the question, and thank you for your role as a patient family advisor. They certainly bring valuable insight to the work that we do. We have a question here. We have another one up in the front here, Tamara, and actually have a couple in the front, but we'll start at the very front.
Hi, we moved here back to the valley 5 years ago and didn't have a family doctor. We ended up seeing Dr. Lapierre. That was a service that the provincial government was putting on for people without family doctors. So we had him for a while. Then we got a nurse practitioner at the Kingston Medical Clinic. He wasn't available, he was off on sick leave. So they brought in another nurse practitioner. She was awesome. Then she left and went to Halifax. And then we got another one, and she is also very awesome. So I guess my question is, it's great that we have physicians or are looking at getting physicians in our province, but we need nursing staff, and we need more nurse practitioners. My goodness, I could almost work in ER, you know, with my years of medical.
Hired.
Oh, no, thank you. But the nurse practitioners, like, honestly, we need more nurses, we know that. When I started in healthcare, it was in 1971, and guess what? We had like, I think we had, before I got there, we had 2 doctors at Soldiers Memorial Hospital. And then we got a bunch, all at the same time. And guess what?
They're all gone.
I'm a baby boomer, and so, you know, now we've got all these baby boomers that are my age, and yeah, it's not good. But I really do feel our nurse practitioners, for the most part, are awesome.
Thank you for that, and we would totally agree with you. I think just to maybe comment a little bit, this year, one of the things which was done was to increase the number of class seats of nurse practitioners from 25 to 40, and we now have 178 in the province, and you know, we can't place them fast enough. And what's very interesting is that I think, you know, I don't know what people think, but certainly within the health system, they've taken on a new value so their scope has taken on a new value, and we certainly know that we need more. It's very difficult to become a nurse practitioner. It's not an easy route. The other thing we're doing as well, which helps, is prescribing RNs. So it's an opportunity for RNs to continue to take some education so that they can prescribe. And we had the first 2 weekends of the mobile clinic, we had a prescribing RN, which was great. And mostly we've had 3 to 4 nurse practitioners in the mobile clinic. So they've worked really well. And so you had the mobile clinic here in Kentville on the weekend. I don't know if anybody went to it. We had 100 people went by the clinic, so I wouldn't say all 100 were diverted from the ER, but I would say a goodly number would have been. But I just want to go back on a point that I wanted to raise on services. So you talk about, you know, hours of operation, and this is something that we're looking at as well. So, for example, Cobequid this past weekend opened on Saturday. They had Saturday hours for some of their clinical services. And what was very interesting, so they saw 192 people, which is great. But what was interesting was the comment from staff. So, you know, not all staff, but some staff said, you know, this week, because I had to work Saturday, I had Wednesday off. I haven't had a Wednesday off in forever, and I really liked having the opportunity to take my kid to school, to pick my child up from school, and whatever else. So we get ourselves into thinking it's got to be Monday to Friday, you know, 8 to 4, 9 to 5, whatever it is, and having people look at things differently and making some of these changes that make it easier for patients are very important. So we are looking at ways that we can expand, extend, and change hours to make it more user-friendly.
And I just thank you for your comment about nurse practitioners. I can tell you, I think, Karen, to a session, we have had a similar comment like that. So it's absolutely been a theme that has come up in all of our sessions, I would say. And that people are the same, similar experience, that have had really good experience with their nurse practitioner and are really wanting us to continue to look at how we can expand them.
So, like one suggestion, I think it was at our very first session in Windsor, when can nurse practitioners have their own practice? Basically hang their own shingle. So it's under discussion. I think we might have one coming, but not a huge thing yet.
Thank you for that. We have, I know we still need to get to the question on this side of the room as well, but I had a submitted question that I'd like to pose. Actually, it's a two-part, but the first part deals with nursing. I think we've touched on that, and I'm sure we will touch on it again. So I'll go to the second part. Is there consideration for having EHS run by the government rather than a private company?
Survey says? Yeah, let's have Jeff Fraser take that. Jeff's our EHS guy. He deals with this every day. There he is over there. Come on up, Jeff, please. But this is not I respect the clapping. It's not the first time that question has come up, and so give it a go, Jeff.
Great question. All right, so I'm Jeff Fraser. I'm the Executive Director of EHS, and I function as a regulator of the EHS system in the province. I joined the department back in April of this year after working 30 years in the operations side. So I did a 30-year stint, retired, went off to a place called 211, which was great. And now I'm back as a regulator, which is a different place for me to be. So as a regulator, what we're doing is taking a much more active role in the day-to-day operations of what's happening within our system. We recognize that what we're experiencing here in Nova Scotia, sadly, is not unique to across Canada. One of the first things I did when I came back to the system was begin to poke some of my colleagues in other provinces. What are the problems you're facing? What are you doing about it? And I came very quickly that there's really no book to pull off the shelf. So we really need to take a look at our service. So one of the things that we have well underway at the moment is our system was built a certain way by design, and that was to have the paramedics in all the communities across the province be very seamless, but they did all the emergency calls, all the urgent calls, and all the transfer calls. So what we do know, after running a service like this size for the last 25 years, that there are opportunities to do things differently. And so the first thing we began to do is really look deep at the data and recognize very quickly that there are a lot of people that we see in the EHS program that are not acutely ill. There's a lot of people who need transportation in between facilities for appointments. These are things that paramedics were tied up on each and every day. And we began to expand. And we were one of the few jurisdictions in Canada that didn't have this option in place. So I won't spew out a bunch of numbers, but I'll throw a few out. About a year ago, 85% of all those transfers that were happening in between hospitals and facilities were done by paramedic crews. We're now down around the 20% mark. So we're really starting to change the service. Why are we doing that? We are seeing some unprecedented demand. So you may have seen a Facebook post today about yesterday. Our service generally does 550 to 600 calls a day. Yesterday, we saw, I think it was 727, 827 calls. So we are seeing lots and lots of increased demands, which of course puts pressure on our emergency services across the province. So if you do many things, you expect many results. So one thing is separating out the transfer fees. The other thing we're taking a really hard look at, we've got a committee at the department that has members of the union, members of the Nova Scotia Health Authority, the IWK, the employer, the College of Paramedics, and we're really looking deep at the number of paramedics we have in the province, the challenges we have with retaining paramedics in our service, and what we need to bring in to be able to operate our system. So we're really looking at the intake in the school system. It's a tough job. There are a few paramedics in here that I worked with many years. One guy's a regional manager. I trained with him 30-some years ago. There's a lot more that we can do. So what is our focus? So we talked about the transfer. The next piece, today we just started a brand new program where we placed a nurse in the communication center. 70% of the patients that we see in the EHS program across the province actually are not acutely ill. Now the 30% are, okay, but about 70% aren't. So we know when you look at the fact that today, if we see 10 patients, there's only 6 of those patients we're going to take to the hospital for. We are able to either decide they're not going to go themselves, they receive care and treatment at the scene. And we have this nurse in place today which works with our physician, which is physically located in the center, and with a clinically skilled paramedic who's in there. They work in a bit of a trifecta, so to speak, where the nurse will look at some of these patients that are calling, and some of it is they're not able to access primary health care. There's a belief that if you use the EHS system, you'll be seen quicker at the hospital, but we're all one system. That doesn't actually happen that way. What we want to do is make sure we put the right, and this sounds really cliche, but this is what we're trying to do, put the right practitioner at the right patient at the right time. And so EMC, and I come up here and I heard the comment was made, we are looking at everything across the system. EMC has an agreement with the department. It's a new agreement that's in place. It's only about a year and a half old, and it really focuses on patient outcomes. And my job as the executive director for EHS is to make sure we have a good system that can meet the needs of the population. We are thinking ahead. We are spending all of our time looking at not just what has happened with our data, but where are the opportunities for us to integrate. And we're much more integrated now than we ever have been before. This clinic that either the deputy or the CEO had talked about a little while ago was a novel approach, something that we were able to help quickly put this thing in place. We will provide a support role. We are all on the same team. My job is to manage and oversee the EHS system, which means I've got good checks and balances in place with the operator. I can't tell you what the future will hold, but I do know the status quo is not an option, and that's why I'm back.
On that, if you could, before he goes,
Away, Scott, or stay here?
You can stay. On that, I won't disagree. EHS and through the paramedics can offer a lot. There's a lot of extra programs out there, community paramedicine, extended care. There's a lot of things that we as paramedics are willing to step forward and work with. Problem is, there's not enough of us. I've heard shortages in doctors, shortages in nurses. I work on a truck, should be staffed by, on my platoon, if you will. I counted today, if we look from Wolfville down the valley, Wolfville ambulance half-staffed, Kentville unit half-staffed, Colebrook unit half-staffed, Windsor 6 o'clock, Middleton 6 o'clock, no staff, Windsor 7 half-staffed, Bridgetown unstaffed, Digby half-staffed. You see the trend. I'm one of 4 platoons. I have no regular partner. Haven't for a while. Brief time there. A few months I was filled in. We are desperately understaffed, overworked, underpaid. I guess my question would be, what's in the works? Where's the help? What's the plan for recruitment and retention?
Okay, great question.
I can take it too, Jeff.
What's that?
I said I can
Yeah,
start
by all
if you
means.
want.
Yep, you go ahead.
So, apologies if you did not hear us say paramedics in with all the other professionals. Totally.
We often are not.
Totally. Thank you for raising it. That was a miss on our part, absolutely, because it is one of the groups that is encompassed by the Office of Healthcare Professional Recruitment. So we are, same as every other profession, paramedics are in the group as well, that they're looking at different ways that we can recruit and retain, because the issue that you've raised also is it's having the right number of people, but then once they're there, how do we make sure that we retain them? So I think Jeff's gone through some of the initiatives that we've taken that we're trying, but I can tell you we are trying everything, and that it's the same as we have issues generally with human resources. There are only so many out that are graduating right now. It takes time to do that, but we're doing everything that we can to try to get them ready as quickly as we can. So I'm sure you're aware that this past year we had an agreement with the college about people being able to start working before they had, you know, completed their licensing exam, or they were fully licensed, I guess that's how I should put it. So we're trying everything, but again, if there are other things that you think we should be trying and places we could go to find people and, you know, get them out faster, we will like absolutely listen to everything that you have to say.
That is not Dubai and UK. We need to recruit from home, where people are going to stay. A company recently recruited overseas. They're not going to stay. You need to have medics that are coming from here that want to be here.
We would
Don't disagree.
Yeah, we don't disagree with that. But I need to be careful too, because I expressed that view at an earlier session, and somebody who had come from another province to Nova Scotia and had been here for 2 years was very unhappy that I had made that comment. So what we know from the evidence is that people who are from an area will generally want to stay in an area. That is not all the time. And for those, you said you moved from Ontario, everybody's a Nova Scotian and everybody is welcome. So we have to find ways. But as a general principle, people who, you know, are recruited to work will generally stay where they are born or from, or their province, or they want to give back to their community as a general principle. So we would agree.
Thank you. We have a very patient person over on that side of the room.
Good evening, everyone. I hate public speaking, just so you all know. So the reason I'm here tonight is to speak for those of us who have been, how do I put it, lesser than the rest of you who are vaccinated. Okay, we have been, might as well call it racism. I lost my job.
No.
Yes.
No.
I couldn't go to church.
Well?
I wasn't allowed to go to church. I have grand mal seizures from a vaccine in the past. Is that okay? Is it?
No, it's not.
No. Okay. And then I was in the hospital because I had the flu vaccine. I was on intravenous. I have worked in healthcare since 1998, and I will continue to look after your parents and my parents, because it's who I am to my core. But I am disgusted that our government did not have my back. Disgusted. I pay their wages with my taxes. Nobody stood up for me when I needed it most, and my employer dismissed me and said I didn't pass probation. They were cowards. No, I wouldn't take the vaccine, and I will never take the vaccine. So we need to get a backbone in society and stand up for everybody, not just those who follow the rules that are absolutely inhumane. There's this thing called human rights. Is there not human rights?
Human rights too, though.
Pardon?
We have human rights too.
Yes, you do.
So is there, do you have a question?
I have no question, because I know the government does not have my back. Because it didn't happen when I needed
They have my
them.
back.
And I have your back too. I have your back too.
So
maybe we'll give.
So here's what I'd say.
Karen a chance to respond.
Here's what I would say. Thank you for making your points. Thank you. I think that, as we know from everything we read across this country and in others, not everybody agrees on this topic. Like, I think we have to agree to disagree. Like, we're just not going to jump over the fence one way or the other way. So what I would share, and I'm sorry to hear that.
I don't even expect thank you, but I don't expect an apology.
No.
I need my voice to be heard for once.
Yes, and that's fair. People are allowed to make their points. So I appreciate the view that you bring. And I would simply say that at the moment, in some of our most vulnerable places in the province, including our hospital system including our corrections officers, including our long-term care, and I'm missing one, some of our community services homes, that the decision was made that those employees must be vaccinated, and at this moment, there is no plan to change that. So, you know, it's an is, and I will also share, just so people know, just to give you a number, at Nova Scotia Health, with 26,000 employees, we have 127 who are not vaccinated. And at the IWK, there are 7. Now, of that, a percentage is administrative and a percentage would be frontline care. So, you know, that's just a fact. I'm not passing a judgment. And so I appreciate that you've come here and I appreciate your points. And at the moment, that's where we are. So thank you.
I actually have a couple questions. One to this point, and I want to speak to it as a vaccinated person. I have a question regarding that issue or that topic. Why are unvaccinated healthcare workers, also in private practices, paramedics, in other fields of medicine, not allowed back to work when we all know that vaccines do not prevent transmission? I would like that answer. And I also have another question afterwards.
Well, at the moment, our policy, as informed by our public health folks, our IPAC folks, and all the rest of it, we have a policy now which just expressed, and no intent or plan to change it. So I have your point, and I think you wrote in that question as well. So we'll make sure that you get a more detailed answer. So I appreciate your point. Thank you.
We have a hand up here in the third row, Tamara, that's been here for a bit. And up here in the third row?
Thank you. I have a question regarding the impact of retirees and the seniors coming from other provinces to Nova Scotia. Now, don't get me wrong, I got nothing against retirees from other provinces. They bring their pension revenue to the local economy. They don't compete for jobs. They're wonderful people. We welcome them. But is it not fair to say that the principle of insurance is you pay into it when you're young, when you're healthy, and it doesn't cost, you're paying more into it than it costs. And then when you hit your senior years, you're drawing more than you're putting in. So, 2 questions. A, what is the net cost of a senior arriving into the healthcare system who hasn't paid into it during their youth and are going to draw on it? And 2, how many of these people arrive per year in Nova Scotia? And B, how much are you getting any money from Ontario and Alberta, where they paid all their money when they were young and healthy? And how much are you getting?
So we don't. I do not have the breakdown. We could get that. General numbers. I won't be able to do the specifics. So, but let me just talk generally about that, because it's you know, we could say the same of some of our students, where we have a lot of students that come from other provinces, and there's large subsidies that go to those universities where we're training students, but then they go to other provinces. So in our federation, it kind of works where you can go here, or you can go there, or you can go here. Your point's not, it's a valid point, 100%, because it's very costly. But I don't think that the province itself is in a spot where that can be solved. I suppose we can show the numbers so that people can see it, so that it's transparent. But we're into federal-provincial relations there. We're into the health, you know, Canadian Health Act, et cetera, et cetera. So it's bigger than certainly Jeannine and I can answer tonight. But I can definitely try to get a few numbers for you. Yeah.
And we had another question in the front here, Tamara. Maybe while you're making your way over, I'll read one of the questions that were submitted. Here's one, little different track. When will we have access to midwifery here? Now I assume here in this region.
That's a Jeannine question.
I might look to my colleagues who spoke earlier for a more specific answer, but I can tell you that We are working, folks are working same as others to make sure that we have a number of vacancies in the province right now that we just aren't, have been unable to recruit into them. So it's a lot of, again, about, whether or not we are able to get the professionals to provide the service, but I'm not sure if specifically, Allison, you have an answer to this area in particular.
So within the Western Zone, we do have a midwifery program. It is located out of the South Shore, so the Bridgewater catchment area, and we are at almost full complement, I believe, right now. Certainly, we do continue to watch population stats and consider what it is, but you can't just have one midwifery given their 24/7 call. So it is a group, and we don't currently have a program in Nova Scotia for midwifery. So again, it is that health human resource, and understanding that it takes about 5 midwives in a practice to actually provide the care to a community in a catchment area to provide that 24/7 call.
Thank you, Allison.
Thank you. Thank you. First, I would like to say that you've come to the Valley, and I think it's really important that you're out in communities. There's a lot of confusion, and I think seeing people who are leading us through some very difficult times is really important for people to see. For that, I wanted to say that. The other thing I wanted to say is I'm fortunate enough to be recruited as a patient family advisor person. Had my first meeting, and it was wonderful. We have great people working here. I really think we've talked a lot tonight about providers, and we can all have a special provider. I'm an old nurse. I think nurses could work to a much bigger scope than they're working. But we haven't talked a lot about people other than giving them care. And I really think we need to think long and hard about the people that live in our communities who have amazing capacities. And how can we better think about, rather than providing more providers, providing them with capacity at times before they even need to get to those providers. And one of the things I've followed closely over the last few years is what's happening in the central region. It's a great big calendar, comes out a couple times a year, of free health and wellness programs. And I've asked a few times online about when those free health and wellness programs, with a variety of different providers providing them, are going to be available in our communities. I was really grateful during COVID to be able to access a number of these programs online, and I would encourage each of you to take a look. They're amazing programs, and to come back to your point, they're providers that we wouldn't traditionally think about providing those. So one question is, we don't have equity across the province, and you're a big funder along with the IWK. So I'd really like to see that across the province, so there are more in-person programs. And the other thing is, we have a lot of great virtual programs. I went on the site today to look at, if I didn't have a provider, how I'd register. We have some significant problems. We have a lot of seniors. You know, I'm pretty computer literate, but I'll tell you, that's pretty cumbersome. So we have to do better, I think, in that way. And, you know, I think that there are ways to think about that. And I know you're doing some great pilot projects, so I'd really encourage that. And the last point, my final point, I think that I have been amazed at the capacity of what you've done in the last few years. I used to work in healthcare, and you have made big, big progress, like really big progress. And I think that we really need to take care of our staff and our providers and our managers. It breaks my heart that we are hearing so many criticisms. And maybe that's what each of us need to leave here tonight with, is what are we going to do to make sure that they know how valued they are. So that's my point.
You said that better than I ever could. Thank you. And I've made the point, I need to see the pamphlet so I don't know what we're talking about, but that's a great suggestion. I thought where you were going with that is, that people have an obligation to do as much as possible with respect to their own health. And we have had that conversation at a couple of our community conversations as well. And, it goes from everything to being homed and homeless. That didn't come up yet tonight, but that's something that the minister has to worry about every day. I don't know how that plays out in the valley. I'm not really sure, but I can certainly tell you when I drive to work, it's very prevalent in the city right now. And we would have probably on the weekend, probably 10 unhomed persons in the ED every weekend. So, it's all a circle. Everything is connected. So it's not just one thing, it's everything.
Yeah, I just would like to comment a bit about your equity comment as well. That I guess it was in the spring, there was legislation passed that requires, it's part of the anti-racism legislation actually, but this piece is a bit broader, and it requires us by July of 2023 to have created a health equity framework. So that work is currently underway. And it's not just about our Department of Health and Wellness, the NSH, the IWK, it's about all of our government departments. Minister Laura's department in the housing side plays a huge role in what we do. Our partners at Community Services, we have very important relationships there, because we know that there's equity in area of the province that we need to work on. There's a number of our marginalized communities that we know we have not served well. Over many, many years, we have not been providing culturally safe and competent care for a number of our communities. So it's a very important piece of work that's going to be done over the next 8 to 10 months to create that health equity framework so that hopefully Nova Scotians will see an improvement. I just wanted to also comment on your other comment about patients and how we talk about them. And I was recently with my executive team in a meeting, and we were talking about it in the context of the hospital, a hospital. And one of the people who was there said, as people move through a hospital, they can go from the ED to maybe cardiology to here to there, but we have to think about them as all of our patients. And I think that we are trying to do that more, right? Because each one of you, each one of your family members, every Nova Scotian is all of our patients. And I want you to know that that's how we're trying to start to think about
thanks, Jeannine. One final point on all things virtual, computer, agent stage, and internet. The internet, speaking of equity, is not equal across the province of Nova Scotia. I have no idea how it plays out here on the western zone, but I'm sure there's probably spots where we could do better. So that has a bearing, of course, on virtual care or other forms of virtual access. And so I'll just share that at the Aberdeen Hospital Foundation, and I think in Bear River too, if I'm not mistaken, or possibly Yarmouth. Yeah, Bear River. So the foundations have teamed up with the community to provide a virtual care setting, so a computer with help, so a place where anybody could go to have access to their virtual care appointment or whatever else they may need on the computer. So if that's something that would be helpful here, or there's a group that is thinking about it, it's worked well in other parts of the province, and so we could certainly share the names of where they have done it successfully. So.
Great, we got about 15 minutes left. I saw we had 3 more hands up and certainly some more submitted questions. So maybe if you could keep your questions short and try to keep your answers short too, folks.
Yeah, it's a problem to keep our answers short.
We're gonna go to the back, to the very back. Oh, okay. I think.
Good evening, everybody. My name is Colin McCachran. I was an advanced care paramedic here in Nova Scotia until June of 2021. I have the pleasure of being joined by my father, Dr. John McCachran, who's been a family physician in the Valley for the last 40 years and continues to serve as in a different role now. I'm also joined by my life partner, Molly, who is an RN working at the ICU at Valley Regional Hospital. There's a lot of unnecessary suffering going on in our healthcare system right now. That's why I left. That's why people are leaving. That's why people will continue to leave. Up until this point, we've seen a lot of lip work regarding what will and will not be done to improve working conditions and minimize the amount of patient suffering that's happening. So my question is this, and this goes to Jeff Fraser and the interim CEO of the Nova Scotia Health Authority. What are you going to do to capture 27-year-olds such as myself and my partner who are looking at other opportunities in other provinces, specifically Newfoundland, where they're offering signing bonuses of $25,000 to $50,000 for 3 years? Now, money is not the determining factor in this, but up until this point, we have seen a lack of action, a lack of commitment, and I think it would go a long way to the paramedics, to the nurses, if they were provided some financial incentive to stay, that we care, we're listening, and we're going to have your back going forward.
Yeah, go ahead, Jeff.
I think I drew the short straw on that one.
I'll speak to it as well.
Okay. Great question. You know, I think I alluded to earlier that we have put together a committee to look at not just recruitment, but about retention. So there are two pieces to this. We have not landed on anything solid yet, but there is a significant amount of work that is being done. I think, you know, I became a paramedic almost 30 years ago, like some of the other people in this room, long before it was really recognized as a profession, long before. I remember my dad one time said to me, "You're never going to make $1 million doing this," and so far he was right. Yeah, he was. But the experience of it, and I left it, and it came back. Things changed. I was very frustrated when I left as well. Very frustrated when I left. And but I came back with the promise that status quo would not be an option. We'd re-engineer our service, make the changes that we need to make. And I agree, there are things around compensation that have to be looked at, but one thing I was afforded an opportunity earlier this year, and I sat in a room in the States, and I listened to one of my colleagues who runs a hospital in the States, and this is what he said to me. He said there's 3 things that he had taken out of what his experience would be from running a paramedic service and now running a hospital. Pay, communication, and respect. Those are the 3 things that people want. So we know that we have to look at our paramedics. Now, I'm not the employer, I'm the regulator. There's a difference in between the two, okay? But those are the things that we continue to look at. As I approach it, as I start at my new role, there are things that are in my control, and there are things that are not in my control. The issue around compensation, we know from looking at, you know, we read the papers, we listen to the paramedics, I've talked to many that have left. It is an issue, so we have to look at that, but it has to be sequenced in with everything else. If we don't change the experience, there's no amount of money that's going to make people stay. So we have to look at it all, and just skipping over, like the alphabet's 26 letters and going from A to Z and not actually changing anything along the way. There are some people that I resonate with, but it will not bring the stability of the service that we need. So we have to look at everything. We have to look at why people aren't becoming paramedics. What about this is unappealing? What can we do to make that experience change? All the while, not telling you that pay is not an issue, but it's not the first thing we have to look at. You know, often I hear from paramedics, and there are a lot of stories, and you asked a really good question, but there are a lot of stories I hear from paramedics. Last available ambulance, you heard Scott talk earlier about half-staffed and all these things up in the valley, you know, that he kind of articulated about a day or what a day looked like yesterday. We have to look at the type of work. So really what we're trying to do right now is begin to separate the service again, trying to make it a bit, let's save our paramedics for what we really need them for. That'll be something that'll help improve the work experience. We take a lot of people to the hospital, and these are people that are desperate, they need our help, but the reality is they may not need us, right. They don't need an ER. So Scott's onto something, they don't need an ER. So what are we gonna do about that? We're gonna create options. Those 30% of those calls that I talked about, those real acuity calls, that's what we want the paramedics for. And I think we are able to make those changes within the workplace, all the while not forgetting pay, and I said it earlier, pay, communication, and respect are the three things that kind of go together. And this colleague of mine runs a hospital, said he's hearing that from an anesthesiologist that was paid like $12,000 a day to show up. Everybody wants the same thing, those three things. They want to be recognized. So we have to change working conditions, not easy. And I'm learning, you know, I came back very ambitious to go through. This is like turning an aircraft carrier with a paddle. It's a big deal. And making this change happen within our system. But I will tell you that my bosses to the left over here are absolutely committed to driving this change through. The minister, if she was here tonight, she would tell you how committed she is to driving this change through. And so I know that it may not be the answer that you want right now, because I can't give you that answer right now. But what I can tell you is that the status quo is not an option, and everything is on the table, and that's the best thing I can say at this point.
Yep, I think that's fair. And I think, you know, this is not the first time I've heard the question with respect to nurses as one, but we could extrapolate, not just nurses, not just doctors, not just paramedics. And, you know, showing value and showing respect, it comes in many ways, and financial is one. We will be heading into, you know, collective bargaining with respect to the nurses. I look at that in a very simple way. This is the largest province in Atlantic Canada, and our nurses need to be compensated fairly, bearing that in mind. So, you know, I have a 27-year-old niece who is a nurse. And trust me, I hear it every day. It's Newfoundland, it's PEI, it's Texas, Karen, I'm going to Texas. I'm going to be a travel nurse this month. I hear it, okay? But I also, you know, need to understand, all right, so great, I'm going to give you a $10,000 bonus. You're going to spend it. And then what? And then what? It's still the same, right? No, I'm not gonna, no, it's not an argument. It's not an argument. I don't want to argue.
I don't want to argue with you either.
Okay, so I'm just gonna finish. So it's not all about the money. Now, one of the challenges is that so much of the work that's being done, it's hard to get it right down to the front line. That's the hard part. That's the really hard part. So I can assure you, it is not lack of government support or will. It's not even money. People aren't saying, you can't spend this, you can't spend this. We're really working hard to transform this system. So it's got to get granular, really granular. So we don't need strategies. We don't need the high stuff. We need to get to the front line, and that's what we're really working hard to do right now. So I'm just asking you to bear with us. We will 100% be going into collective bargaining, particularly with your life partner, Molly's group. They will be well compensated and fairly compensated. They are only one group. We've got many others as well. So it's finding the ways to show respect that, you know, it's hard to do. And that's why, you know, the point was made about we have to be kind. Of course, like, it's not fun when you go to work and people are yelling at you and screaming at you, and, you know, it's just not, that's not productive, fun, satisfying, or nothing. Sunday night I'd be sick to my stomach if I had to, you know. So I do get it. The hard part is, how do we show that? How do we get there?
We have a question way in the back.
Hi, yeah, I have a question. Before I do, though, I just want to comment on the young lady's comments about 20 minutes ago. I think the word that she was looking for was discrimination. And for any of you that don't agree with that, I challenge you to look up discriminatory practices under the Canadian Human Rights Act, and you'll find your answer there. However, my question in regards to the vaccinations, a year ago, we were going through the vaccination procedure, the mandates. 2 vaccinations are required. then there is no mandate towards a third or a fourth booster. So can you tell me why you stopped at 2 and you haven't gone ahead with 3 or 4 or even beyond that?
We can get you a more detailed answer from public health, but the 2 is considered, it's what they consider the primary series of vaccination. And so that's essentially the answer, is that that's what's considered to be your series, and then the boosters thereafter.
So, but if what you're saying is work, then why are the people that didn't get them still off work? Because if they wane, if the medication wanes over time, which apparently it does, I don't know, you're saying that these people can't come back to work even though people who got 2 and haven't got a third or a fourth are remaining working. This confusion.
I think that's, yeah, I think it is a policy that's been adopted, and with respect to the science behind booster 3, booster 4, we'll get you an answer from public health specifically, so thank you.
I just want to say, I'm sorry, may I just add something to that? That when people are forced to lose their job, that contributes to homelessness, right? So homelessness is a problem, we're being forced to lose our jobs. The government is making poor decisions.
We did have, thank you very much for that. Leo, I know you had a question about the emergency department at Soldiers, maybe, and I think actually I think we're about at time. So if you could make it quick.
Yeah, just very quickly. First of all, I never miss the opportunity to thank and express gratitude to those who work on the front lines of our healthcare system, and those here tonight. And by extension, those across the province. The last 2 or 3 years have been indeed very stressful and challenging times. Sometimes there's a domino effect in the system, and we're seeing this now with reduced hours and sometimes outright closures in the ER at Middleton Hospital. The statistic may not be quite as correct today as it was a few years ago because of the closures that happened there, but it's the 9th or 10th busiest ER in the province. And so when it's closed, it's that extraordinary pressure then when you come here to Valley Regional. And days when it is closed, the next day, and I know 2 people today who after 4 or 5 hours left Middleton when it was because they were not seen up to that point and looking dismal for the rest of the day. So we have extraordinary pressure here on Valley Regional. I think you sometimes have to target those areas in order to make those little incremental improvements and make sure people are getting the care they need. Also in a military community, there's that underlying current that if I were still in Comox, this wouldn't happen. Or if I were in Gagetown, this would not happen. The other point I want to make, and it's a very important one, there's been some alluding to it tonight, but the demographic wave that's coming at us, the oldest baby boomer is 75. We have to look at upstream work on geriatric clinics and getting people in for checkups so that the small problems can be addressed before the big, expensive, and bedtime in hospitals can be prevented. I think we absolutely, and being the first or second oldest province in Canada, we can be a vanguard in this area of true geriatric interventions before the serious business happens.
No, that's an excellent point. And not only that, I guess just to add to it, we also have world-renowned, experience here with Dr. Ken Rockwood, and he's better known outside of Nova Scotia than he is inside. And with his knowledge and what he can bring to the table, we need to fully leverage that whole, we haven't seen nothing yet in terms of the boomers coming forward. So we have our eye on that number, and I really appreciate you making note of it. Thank you.
We are at 9 o'clock. I know there's still many questions out there, so please, if you haven't had a chance to ask a question, fill out a card. I think there's opportunities to put your email address or some way to contact you. We'll work to get you a response. There's also opportunities to ask questions online as well, the same place where you would have went to register for this event this evening. I do want to thank everyone for coming and for your thoughtful questions. Jeannine, Deputy Minister, Karen, thank you very much for the, it's not easy sometimes to ask these difficult questions, and I know it's not easy sometimes to answer them, but I do want to thank everyone for participating, and there certainly will be more to come.
Thank you, everyone.